I've not done this for a while, so it's about 18 months since we ran through our last clinical reasoning panel. So help me along, won't you? Everybody at the back as well. But welcome to the first session in the panel. And obviously what we've got is hopefully a very interesting patient that we'll be running through. I don't want to see what it is until we disclose it in stages. All has seen it. But what we want to do is explore what you're thinking and why you're thinking more than what's just up here on the screen. So what I'd like you to do in order is to think of just one question, your first question that you're going to ask our patient, because our patient's already come in. So you've just come into the cubicle. Kevin's here. Julie, I want you to ask him the best question you can, the first question. What would you like to ask him and why?
Well, do we have his details? Can I ask him what age he is first of all, or is that?
You can ask his age.
Yeah, what age are you?
I'm 43.
33.
Does that make a difference to how you approach this patient?
Not really, but it'll hopefully help. Not really, but it'll hopefully help me as I'm going through when I'm looking.
Would it be different if he turned up when he was 14 or?
Just the pathology structures and whether
Yeah.
it's more of a degenerative problem or...
So what would you expect somebody in their mid-40s to come in with?
They may have early signs of degeneration. They may not. It might just be something you have in the back of your mind.
As opposed to a teenager?
Yeah. If a teenager had come in, we don't know what he's presented with yet, but we would maybe be, we wouldn't be thinking degeneration, we would have in the back of our mind. We'd be open to other pathologies or
So,
things like that.
have you ever seen a teenager with degeneration?
Mm,
I have.
Yeah, I've seen
I suppose it's possible. There's strange conditions that are maybe not as common, but yeah, you probably shouldn't close down on that.
Okay, but it's just interesting what we're looking at already. We've only just asked age, and automatically you would see a person as they walk in, and what we've got at the moment is already a set of preconceived ideas based on what they turn up like, what they appear and how old they are. So that's a fair question. Shona, what would your next question be? You know how old he is?
I might ask about your occupation.
Van driver for the NHS.
What did you find out from that question?
He's obviously, being a driver, he may spend some of his time, well, obviously in the van sitting, but we don't know if he's delivery, if he's then lifting and doing some sort of, walking, delivering. But you would be starting to think about the positions he might be adopting through the day.
And obviously we'd probably take that a bit further and go into the depth of it to get the full understanding of it. So we'd ask him how long he was, what his day entailed as a van driver.
What do you think the most appropriate time to ask that is?
Well, probably.
I'm talking about efficiency-wise when we're going through.
Well, if we'd
Um,
started with that question, if I was asking about that now, I might go on and ask him about that while we're speaking about it.
I suppose it depends on what his problem is. If it's
Yeah.
absolutely nothing to do, or he
Yeah.
feels it's nothing to do, if maybe it's his ankle, or maybe it's something more related to his job. We don't know that yet. So
So maybe.
it would maybe come up in the AGS and EASES or in the 24-hour.
You could
so
probably
maybe-
go into it in more depth in his social history, but at least at this stage you're getting an idea of what he's predominantly doing throughout the course of his day when he's at work.
Mm-hmm. So when he comes in like this, it's a question of how do we make our assessment the most efficient we can? Because we don't want to be asking him about, a lot of detailed questions that are not relevant to his particular problem. Okay. So Sheila, what would you ask next?
I suppose at this stage, if you've established his occupation, you could ask at this stage just briefly about his hobbies, what he does out with work.
Okay.
Hobbies, what do you do?
Well, I work obviously half 8 to half 4 on Friday, and on a Saturday I have my own car valet business, which I work more or less every Saturday.
Okay.
Never here.
Brad, louder. Something missed that.
And any other physical activities or
No, I don't do
hobbies?
anything. I don't have time to do anything else. I
Okay.
just do the Car Valley on a Saturday. All day, every day.
Okay.
Okay, is that enough background information at the moment?
Yeah.
Right. What would you like to move on to next, Julie?
What's brought you here today? What have you come to physio with?
This kind of pain in the back here. It's no settling, it's pretty sore.
And that's your main problem. That's
Yeah, that's my main one. And then sometimes I get this pain, kind of.
Could you stand up and show us?
I'll stop you there. Julie, why did you ask that question? Can I just ask?
Well, I wanted to, I mean, obviously I don't have a referral or anything in front of me, but I wanted to find out what he felt was his main problem and why he'd come to physio. He told me about that pain, but obviously at that point we hadn't established whether there were any other symptoms, and I wanted to work out, well, A, we could lead on to other symptoms, but to find out what his priority was.
Excellent. Did you understand the efficiency of that question? Because it's not asking you, anything that might be less efficient. It's probably one of the best ways you can ask it in what's put in there. So,
Okay. So you were saying, could you stand up and just show us whereabouts the pain is?
It's like, thank you, yes.
Okay.
And then sometimes, once it gets sore, sometimes I get
Does it ever go above that area that you were just pressing?
No,
Good to
just,
know.
just on this side.
And does it always stay on that side, or does it ever go
No,
over to
just
the
on
other
this
side?
just
Okay.
And can you show us exactly where it goes down your leg again, just mapping it with your hands? So it goes over your buttock and down the back of your leg.
Starts from a bit here.
Starts from the lower part.
And then down here.
And it stops at the knee.
Oh, aye.
okay.
No, no.
Can I just stop you there? From what you've got there, what are you thinking? Shona?
Something possibly, well, lumbar spine, right-sided, with some kind of referred pain. We don't know if it's neurogenic pain in nerve root or if it's sort of nociceptive referred pain.
Sorry, I don't think they can hear
Oh, right.
you, so can we all just speak a little bit louder? Would that be okay?
Okay. With, we don't know what's caused it or what's sort of brought it on, so whether it's a gradual onset or it's a sudden onset or anything. So the exact structure, I still wouldn't be.
Do you think we
Okay,
can
so-
rule out SIJ as
So
well?
you're thinking lumbar spine,
Uh-huh.
and Julie, you're thinking...
I'm just saying, because of the area that he's suggesting, we probably can't rule out SIJ at this point either. And the other thing that I was wondering is, he presented a pain here and a pain from the ischial
Pain does go down by
tuberosity.
my knee, actually.
Does it? From the
Does
ischial
go below
tuberosity.
the knee.
I was just wondering if there was anything in between those two
Yeah,
symptoms.
there's like,
Well, just before we get to that, because we need to know why you wanted to follow up on some of these questions, is there anything else you're thinking about at the moment with this, Jim?
I'd be thinking probably lumbar spine at this stage, possibly L5S1 level. I agree that you probably couldn't rule out other structures like SI joint at the moment either.
So can you tell me why you're thinking about L5S1 level?
Just with the distribution of the symptoms into the posterior aspect of his leg, and referral below the knee as well.
Okay. Does that ever happen with any other level?
Yeah, I mean it could be L4, L5.
Okay. So I'm just intrigued why you would go for L5S1 as opposed to any other area. So any
I suppose that any of the sort of levels in the lumbar spine could take a referral down the posterior aspect of the leg.
Mhm. So any reason why you go for L5S1 first?
Just with the distribution.
Okay. So is there a characteristic there that you can identify for us that would localize it to L5S1?
In terms of,
What he's described to us.
I know I am. I feel in my head as well.
I mean,
We
there
probably
there's
can't
no right
be
or wrong answers to that.
specific
You know, I'm
at
not
this
trying to
point.
trap
No,
you, I'm just trying
no.
to work out why you're looking at saying it for that level.
I suppose if you're thinking about where the pain refers, sort of S1-2 area, or the sort of sciatic nerve being innervated by, well, L2, 3, 4, 5.
Shouldn't I going to clarify now?
Shouldn't have got myself into that one.
Love to help you.
But you could you couldn't rule out something there. So looking dermatomally, but the way he's describing it, it does look above. Well, I don't know from what you said, above the SI joint. There is something in the lumbar spine there, so you couldn't rule out the above L5 either.
Mm.
Okay. So if you write down now, and just hang your hat on something, what you think the main three structures are in order of priority from what we've got. Okay, Julie, what three have you got?
I've got arthrogenic, neurogenic and myogenic. With arthrogenic, I've put sort of wide, I've covered my bets, L4 to S1 possibly. And again, that's because if the two pains are related, then it's the distribution, the dermatomal distribution, and also the region, it's lower lumbar is the region that he was relating to. Neurogenic, again, I don't feel we've got enough information to determine, but because the way he was spreading the pain with his hand, it does look like the two are related. So that could be peripheral neurogenic, that could be nerve root, or it could be, I suppose it could be facet referred and not neurogenic at all at this point. And myogenic, I don't think we can rule out hamstrings at this point because although it goes below the knee now, so we probably can rule out hamstrings.
How far below the knee does it go? Just to it goes right down to your ankle,
Okay.
the back of your ankle, not into your foot.
No.
Right.
So I might change my myogenic then to, I suppose we can't rule out discogenic at this point as well.
What about sacroiliac?
Oh yeah. Yeah, again, I mean I still don't think we can rule out at this point, even though the pain does go.
Is there anything you can rule out from what we've got so far?
Possibly myogenic, but I don't think we've got enough information at the moment.
Okay. Shona, what about you? Is there anything you think we can rule out?
Well, we've kind of established that it doesn't go below, above there, so sort of thoracic is covered.
So does that
It's-
mean when we come to do our objective, because this is what we're organising our objective really with our subjective, isn't it? Does that mean in our objective we don't look at the thoracic?
Not on your musts. I wouldn't say it's a top priority. It might be something you could go and look at if you're looking posture or sort of ergonomically.
But you can see how at this stage we're already shaping what we're going to plan to be doing. And also in the back of your mind you're also probably planning on how you're treating this patient, whether you realise it or not. Okay. What other structures did you have, Shona?
First of all, I had arthrogenic, so covering kind of sort of facet ligament. I suppose you could put disc in that. L4 to S1. I'd put for number 2 maybe an early sort of degenerative type of thing. And thirdly,
Sorry, degenerative where?
Facet joint,
So lumbar spine.
lumbar spine, from L4 to L5 S1. And thirdly, I'd query SI joint, but I do wonder because it is a bit, it does come up above the SI joint and into the lumbar spine. I wonder whether that's
But you've
likely.
ruled out L3, 4.
Well, I mean, the sort of pattern of referral doesn't suggest L3, 4. But I wouldn't rule it out.
Yeah, I'm just thinking that as well. Probably can't rule it out.
No.
No.
We're all getting more and more uncertain.
Yeah.
Okay, Sheila, what do you think?
I put down arthrogenic is the first, and again with arthrogenic it could be facet joint, ligamentous, degenerative disc of the lumbar spine, again not ruling out any particular levels at this stage. Neurogenic as second possible cause of the pain, and again for my third I put SI joint.
Okay. What would you like to do now with the patient? He's here for as long as we like. You can ask any question. Sheila, what would you like description, and how will that change what you're thinking about at the moment?
The pain,
The
so if it
description.
tends to be more of a deep ache, I'd be thinking more in terms of arthrogenic type symptoms, and if he was describing shooting, sharp, burning pains, I'd be thinking more of a neurogenic type pattern of pain. Kevin, can I just ask, first of all, do you feel the pain that you get in the top of your spine and coming down into the leg, is that the same pain?
No, this pain here is like there all the time. You know, it's a kind of, it's a dull ache, and I just can't get rid of it.
When you say it's there all the time, Kevin, is it there 24 hours a day, every minute a day, so it never goes away? Does it change in how intense it is? Is it sometimes sorer, easier?
Just depending on what I do.
Okay.
It gets worse.
And if you had to describe your pain on a scale of 0 to 10, where 0 is no pain and 10 is the worst pain you could ever imagine, when that pain's at its worst, what would you give it out of 10?
I'll say about 6.
A 6.
6, yeah.
And when it eases off, when you get some relief from it, what would it be in that scale?
No, maybe about a 2, but it's always there. You know, it never goes
Okay.
away. So,
And how would you describe the pain that goes down into your leg?
Can I just stop you
Yep,
there?
sorry.
So you've isolated what for us? Isolated.
That he's got two different presentations of pain, so he feels that the pain in the upper part of his lumbar spine is different to the pain into his leg.
Okay. And what else have you established with that?
Established a description of his pain, how frequently it's there, if it changes in terms of intensity and what intensity it goes to in terms of his VAS.
Okay, and does that change any of your ideas of your working hypotheses?
No, I would still be thinking with his description of deep ache, I'd still be thinking it could be arthrogenic in terms of the structures causing his symptoms.
What about the constancy of his pain? What does that say to you?
It's quite a severe pain. If it's there 24 hours a day, it's relatively high in VAS at 6 out of 10, but it is changing in intensity, so he does get some relief from it.
Okay. Does it change any of your working hypotheses? Does it mean that you're still thinking about possibly SIJ with this patient?
I would be thinking less about.
I mean, why would you be thinking less of SIJ with that?
Because the pain is more the pain is constant rather than more. I would expect for SIJ that it would be more intermittent type presentation of symptoms.
Sheila, would you agree with that?
I don't know. I suppose it depends how severe the symptoms are. If you have got any structure can cause constant pain depending on the severity. But I suppose with the fact that he can bring the severity of up and down, you might be thinking more mechanical, and that is presenting, more normally it would be, it's not a constant, unremitting kind of pain. You can bring it up and down.
So you're thinking this is a mechanical problem?
Mm-hmm. Yep.
I don't think we can rule out SIJ at the moment. We don't think we've got enough. We don't know what the pain feels like yet, and we don't know what's increasing or reducing it for him.
Okay. Would that make all the difference for you?
Well, yeah, knowing what is aggravating and easing
Yeah.
factors are
Yeah.
might make a
We'll get
difference.
to that with,
Yeah.
with probably the next panel.
Okay.
What else would you like to know and clarify on the body chart and why? Now, I want you to think carefully of what you want, because if we've got one question each, to think about the most efficient way of extracting that information. Shona, what would you ask next and why?
I'd maybe want to know if it was deep or superficial, just as an extra bit of information on that pain A.
And how would that help to clarify what you're thinking about?
It would allow you again to think more of structures that are deep in the lumbar spine. Visceral, deep is deep, and if it was more on the surface again, it would sort of lead you towards different structures.
So do different structures refer sensation to the skin or surface feeling, and different structures go and give you a deep sensation? Is that what you're saying? So I'd like to ask that question.
So can you tell me, does your pain feel quite on the surface, or does it feel deep inside?
No, really deep. I can't
Right.
touch it.
Right,
It's
okay.
always
Mhm.
there.
Okay. That's fine.
Ache.
You just said it, did you? How would you describe that pain?
An ache.
An
It's
ache.
always there.
Okay, and it doesn't change in symptom, it just always feels like
always
an ache.
there, but it gets worse. You know, it's
Okay.
It just depends.
Okey-doke.
Yeah, I think we've got enough for pain A. We've established that it's a constant pain, an ache, deep, and it varies in terms of its intensity.
Okay. So you're quite confident that you'll be 100% right when we flash this image up of the body chart in a minute,
Of A,
of A.
yes.
Good for you, Shona.
Sheila? Go for it. And you?
Yeah, I think so.
Okay. What else do we need to find out on the body chart at this stage?
The symptoms into his leg.
Okay. Would you like to carry on?
Kevin, could you describe, you said that you get the pain coming down the back of your leg and going down towards your ankle, it doesn't go into your foot. Could you describe what that pain's like?
It's like just a sharp pain. You know,
Sharp
yeah,
pain.
and kind of a big rush pain, you know, a sharp pain that I've got to take my leg back off. Also, just comes, you know, when this is so here, and sometimes this just goes.
You're pointing to it a wee bit at the side there. Do you feel? No, is it right? It's more at the back, right? Okay.
So
Sharp pain.
it's a sharp and it tends to be like a rush of pain down into your leg.
Yeah.
Is it there all the time? Does
No,
that pain
no.
comes and
Yeah, it
goes?
comes and goes.
And again, how would you describe it in terms of 0 to 10 if 0's no pain?
I mean, sometimes I don't have anything down there,
Mhm.
you know, but sometimes it can, it's a way up to, what did I say, 6 out of 10.
Okay, and again, like the other pain, does it tend to be a deep pain, or could you put your hand on it? Could you touch the pain?
No, I can't touch it, but I wouldn't say it's a deep pain, it's something that just makes me takes the breath away from me a wee bit.
So it'd be more of a superficial pain.
Yeah, but something you can't touch
Well, you
it.
can't touch.
Can't touch it.
Can't touch it.
What did you learn from that?
Just with the description, the sharp sort of rushing pain, it would make me think more neural type structures. And with the information Kevin gave about pulling back into flexion, taking attention off the neural system, sounds as if it helps to relieve his symptoms, although I'd explore that more in terms of his ags and easing factors.
This is something that patients often do to us, isn't it? They already show us a lot of the relieving, a lot of the antalgic positions, and you'll pick this up automatically and maybe not, write it down or register it, but it's one of these subconscious sort of bits of information that we pick up. So, yeah, absolutely right. And did it tell you anything else about that?
He also said, which would probably ask a bit more about, that it starts here and then it goes down the leg. So what we'd probably ask about, maybe following on from that, is the relationship between the two pains.
Okay, would you like to ask?
Yeah. Excuse me, sorry. You said that it starts in this area here and then you feel a rushing down. Is that whenever this changes at all, or how is it related? How do you feel that?
Depends on what I do. I mean, sometimes I can just have this.
Yeah.
But
That's
when this gets sore, this gets sore.
Okay,
You know,
and does this always have to be sore first of all for you to have that pain, or
yeah,
does
I
it?
would say so, yeah. Yeah, this is always here.
Right.
Do you never have the pain down the leg without the, well, I suppose your back pain, so
It's always,
okay.
if it's here, this is
Right,
here.
it's almost there anyway.
So can I just ask Kevin, is it when the back pain gets really sore that you would get the leg pain?
Aye.
Yes, so it's when it gets to its most intense you would get the pain down your leg.
Yeah. Because I can do some things without it, but other
Okay.
things I can't.
Okay, just to say that last question Sheila has just asked is quite good, because sometimes with the relationships it's very hard, as we've seen when you practice, not to put the words into the patient's mouth and say, do you get those two together, and you're waiting for a yes answer, or so what Sheila's just done is just at the end of that it's clarified exactly so that we can actually see what the situation is. So that's often a good thing to do at the end of when you're discussing relationships.
Are you happy with the questions on the relationships? Okay. It's sometimes worthwhile asking the reverse question as well. When somebody's presenting with two at least areas of pain, we also need to know is there an alteration when the legging, if you have an increase in the leg symptoms, for example, is there then any change to the level that's happening in the back? Okay, because what you've asked is from the back coming into the leg. So if one level's increasing, you want to then see that the other one follows. But if you then ask the question on the leg, if that increases, what happens to this other area? So what happens to you if your leg is really bad and you're getting that shooting pain? Can you ever have it like that and the back be relatively good?
No.
Okay.
The back's always, the sore back always comes with just the sore leg, and the leg's never there on its own.
And I asked him a leading question on purpose, so I purposefully led him into saying, well, when the back's good. Okay. So are you happy with the establishment of relationships of pain in this case? What else would you like to ask on the body chart?
Pins, needles and numbness.
All together.
It's all three together.
Yeah. Do you have any other symptoms at all down the leg or into the other leg?
No.
No,
nothing
and
at all.
any experience of sort of pins and needles or numbness or tingling or anything like that?
No, none
None.
at all.
Julie, can I ask you why you're shaking your head when you're asking that question?
I have no idea. I don't even know what I'm doing.
Yeah.
You don't.
You tell them you don't.
Your wife, no, you don't like that.
Oops.
I'm fascinated.
Sorry, I didn't realise.
You're in brown.
What about, are we happy with the body chart?
Yeah, you'd maybe
Yeah.
tick off the other,
Yeah.
tick round all the other areas just so you've clarified that there's no symptoms anywhere else.
And I would just ask you don't get pain on the other side of your back, the other buttock, into your leg, just to be quite specific about it.
Okay.
No, it's just
Nothing
just
at
on
all.
This right side, yeah.
And no pins, needles or
No,
numbness.
none at all. None at all.
Yeah, careful with the leading questions. Are you happy enough now that we can draw up the body chart? Everybody just make sure that you can draw out the body chart from what we've heard so far, and that we'll have an accurate representation of what has been recorded. We'll just wait a minute. Sorry. You don't have much to do today, so it's good.
I'm so glad.
Now, Kevin, do you need to get up and move around, or are you
Yeah,
quite
I'll
okay
do
to
that.
move around? No, you're right there.
Oh, yeah.
Okay. That's it. See, they always get sore when they sit down for a while, don't they? They need to get up and move around, or sometimes need to lie down when you assess them. And Okay, you've had a shot at putting that body chart together.
No, Carol's just giving it out, so I'll flick it up.
Oh, it's already given out, so let's have a look. Luckily they asked that first. Okay. Panel, did you get the pain all the way down to the ankle like that?
Yeah.
Was the intensity of the pain the same all the way down the back of the leg for you? Or was it more intense in the thigh or the calf?
No, we didn't understand.
Why might that be important?
Might give, if it's neurogenic, might give you an indication of how irritable the problem is with the leg pain.
So how does leg pain give you an idea of irritability?
I'm just wondering if it's, I don't know, maybe not, but maybe if it's more peripheral symptoms, that could give you a level of how irritable it is.
Okay, so peripheral symptoms tends to be more irritable? Is that what you're saying?
I don't know what I'm
I
saying.
suppose maybe it would give you an idea of more of the exact level that was, you know, if you were getting pain down the leg, if it was, say, more intense. Although, no, you would expect it to get less intense as it went down, would you?
Not necessarily.
No.
I suppose we
Uh,
didn't ask enough from the distribution of symptoms to establish if there was a change in the intensity as it went down his leg.
Because he's described this sharp sensation going down the leg, and we didn't know if it was worse below the knee or above the knee. And sometimes that's very important if we're trying to localize particular nerve root compression, because it's usually worse below the knee. And that's a very important thing that we missed when we were looking at the body chart. What else do you notice about the body chart?
It's cleared other areas other than the opposite leg, and so it's cleared.
It's cleared the head and the neck and just been completely thorough, just to
And
check
not cleared
that
the feet, has it?
it's not cleared the back of the feet.
We're being picky.
Yeah, I suppose it's,
What about the information that we've got there? Does that change how your working hypotheses are developed?
starting to probably think that there is a sort of neural or referred pain. A nerve neurogenic may be involved.
So what are you thinking about the source of symptoms here? You thinking that the nerve itself is the source of the symptoms, or is there something?
Maybe more peripheral referred, because there's no pins and needles or numbness. As far as we're aware yet, we don't know for definite. From something on the right side of the lumbar spine. The
so you're saying
arthrogenic.
it's more into the lumbar spine than into the leg on this case?
Looking at the VAS, they're both 6 out of 10, so at worst. Although it's constant in the back, so it's something coming from the back into the leg, referring into the leg.
And the relationship.
Yes, I mean that's
Yeah.
exactly it.
Yeah.
How many problems are we dealing with here? How many problems do you think there are?
One.
Okay, that's what we really want
Yeah.
to know with the body chart, isn't it? Because if we've got the whole body chart shaded in, and you see patients with a whole lot of shaded in, you know, there might be multiple problems. Okay, and it may not be peripheral. So, what else can we gain from that body chart, Sheila? What strikes you there is when you see the picture go up, what does it tell you?
Just from a first glance at it, the main presenting problem, Kevin's main presenting problem is pain A. It's the most intense, it's constant. It does vary in terms of its symptoms and then the relationship with the pain down into the posterior aspect of his leg.
Has it changed the working hypothesis?
Again, like Shona, I would be starting to think that there's more of a neural component
Because of
the description of pain B and the relationship between pain A and pain B.
Okay. So do you think that neural component is a primary source of the problem? Or do you think that neural component is secondary?
I think secondary.
I think it could be secondary.
Okay. Anything else you'd like to ask about the body chart of the patient? You're lucky you got an easy one. Okay, I think we're ready to swap over. Thank you very much. Hope you enjoyed that.